Nun, vielen Dank, Professor Hardell.
Okay, thank you so much, and guten Tag. I'll try to give an overview of the cancer risks and how the risks are downplayed by ICNIRP and some other agencies. And actually, in the last picture that Professor Belpom showed, we had the possibility to measure radiofrequency radiation within the WHO office in Geneva. And it was amazingly low in those areas where we could measure at that time, at least. So at that time, the WHO officials were protecting themselves. It was below the Bioinitiative report guideline, which is rather low compared to ICNIRP. So let's see. Yeah, I will not go into this picture since it was covered earlier this day, but I would like to remind that this is made for 835 megahertz GSM phone, and we don't know how it will actually look like for 5G. Those measurements have not been made as far as I can know, which is one of the problems with 5G. I will also remind about the development of the mobile phones. To the left, we have the old ones, and as you know, the first ones had an antenna that could be drawn out from the head, and actually this was somehow a precautionary aspect because it gave lower exposure to the brain. Then we got the smartphones and with an inbuilt antenna in the 1990s, and now we have the last versions of the smartphones where they have maybe 5 or 6 different antennas. One problem is that one antenna is located at the base of the mobile phone, as you can see to the right, and this gives a high exposure to the thyroid gland, and actually it is, according to what I've seen, as high to the thyroid gland as it is to the brain. And as you may know, the incidence of thyroid gland cancer is going steeply up in many countries in the Western world, and especially of the papillary type, which is the radiosensitive type of thyroid cancer. This is also confirmed in a case control study. As we have already heard several times that IARC made an evaluation in 2011 of radiofrequency radiation and came to the conclusion that it is possible carcinogenic to humans. That is group 2B according to their definition. And this was based on the increased risk for glioma, the most malignant brain tumor, and also acoustic nevrinoma, the tumor which is located on the hearing nerve. And this was a conclusion which made by the evaluation group. It's also, as we have heard previously, so that IARC has strict regulations who can be involved in these evaluating groups, and you heard about Anders Albom, that he was expelled 2 days before the meeting because it was revealed that he was working in his brother's firm, which operated for the telecom industry in Brussels. Anders Albom was aimed to be the head of the epidemiology group, which would have been some kind of a risk to the risk. I was part of that evaluating group on cancer epidemiology. I have, by the way, worked as a cancer doctor for many years, and parallel to that, as research on cancer risks. I will give just a summary of the glioma risk. That's one type of brain tumor, as you can see on that picture over there. Usually, especially the high grades are infiltrating, so they are growing out in the brain like fingers. So it's extremely difficult if you have a glioblastoma multiforme to operate the whole tumor. Usually you get some rests left, which will regain the growth in some time, and often the median survival is just 1 year. We have the large interphone study, which was made by IARC and associates, and I would say that IARC is an independent area of WHO. they had the cumulative exposure of 1,640 hours, as you can see, which corresponds to roughly 30 minutes per day for 10 years, and came up with about doubled risk for ipsilateral glioma. That's on the same side of the brain as the mobile phone had been used. This was replicated in a much smaller study by Corot, French study, doubled risk based on low numbers. And this is finally the summary of our studies over more than 10 years, and we find about 3 times increased risk. If you took the meta-analysis and combined these different studies, it's a highly significant risk. It's 2.5 times increased risk for glioma, and also this is significant with a rather narrow confidence interval. If we look into acoustic nevrinoma, which is the tumor that appears on the hearing nerve, 8th cranial nerve in this area, goes into the brain, and as you can see that there is almost free access of the radiation to that area because you have the ear canal there and not any bone structures that can reduce the exposure. And I would say that this is maybe the signal type of tumor with an increased risk. We can see here that the interferon study gave 2.3 times increased risk, and our 3 times increased risk. Again, ipsilateral exposure. They had used the mobile phone on the same side of the brain as the tumor appeared. And the meta-analysis gives 2.7, which is almost a 3 times increased risk. Of course, these tumors are rare, so it's not easy to look into cancer statistics and find the increasing incidence. But anyhow, there is a statistically significant increased risk. We assessed also use of cordless phone, DECT phones, which we think are similarly dangerous as the mobile phones. No other study group has really looked into the DECT phones, and ICNIPS, or the interferon study, they said that the emissions are so low, so we don't care about DECT phones, which is actually not quite true. This is a short summary of the NTP study and brain lesions in male rats. And they used 2 modulations, GSM and CDMA. And overall, there is an increasing number of tumors in the exposed groups, both of malignant glioma and glial cell hyperplasia. And the glial cell hyperplasia, they are precursors to malignant glioma, so they will transform by time to glioma. So then there is evidence from animal studies, the same tumor type as found in human beings. Schwannomas, they are tumors that are developed in the myelin sheath of the nerves, and here they found these nerves can be found in the heart, and actually they found an increased incidence of schwannomas in the heart, but also in other sites of the body, and this was a significant finding. So now the NTP came out with these results from both for glioma and schwannoma. Schwannoma is the same tumor type as acoustic nevrinoma. So we have a fit between epidemiology and human findings. The Ramazzini Institute study in Italy, as you may have heard about, they have published similar findings in the rats. They have, first we can look into this picture. They have male and female rats. The controls, there are to the left, and then the exposure is 5, 25, and 50 volts per meter. And as you can see, these are all below ICNIRP level of 61 volt per meter, and they represent what you could say base station exposure in the environment. And overall, we find an increased incidence of glial cell proliferation and glial cells, if you can see to the left, in all these groups. In females, this is a linear response. It's not sure that we should have linear dose response effects because of that's not always the case. Like for hormones, there is no linear relationship between exposure and cancer risk. And again, the other finding is on Schwann cell proliferation and schwannoma, and the same type of figure. And you can see here that there is an increased incidence, especially in male rats, for the schwannomas. So now at the same time, we have two types of studies coming up with the same types of tumors. Regarding NTP, they have actually found also other types of tumors like prostatic cancer, and in Ramazzini they are studying other sites also. So as I heard, there will be later this year maybe a publication on those findings. Both studies have found DNA damage also. So, well, how did ICNIRP play with these findings? They published in Health Physics some 2 or 3 weeks ago a review of NTP study and the Ramazzini Institute study. I will just discuss a few things they discussed. First, they say that there's no verified mechanism for radiofrequency radiation and carcinogenesis. But they disregard, as we have heard, about the oxidative stress and DNA damage. So this is a false statement. One of the worst falsifications they make is that they say that histopathology was not blinded, so that those who reviewed the slides from the animals, they knew if this slide came from an exposed rat or if it came from an unexposed rat. And this is not true, of course. I mean, that would be a violation of principle scientific regulations if you would do such a stupid thing. So why do they publish that? Their main argument, one of the main arguments against the NTP study is that there was an increased body temperature and that heating was a cancer risk. Now we know very well that heat is not a cancer risk. If you take a sauna bath or you live in warm areas, you don't have an increased risk for cancer. So I don't know how they invented this. They also said that only our study group showed increased acoustic neurinoma risk, which is not true. I mean, we had similar findings, for example, in Interphone. And they furthermore ignored the similarity between the tumor types found in human epidemiology and animal studies. And that's rather, is not so common that you find the same tumor types both in animals studies and in humans. I don't think that smoking gives lung cancer in all rats, for example. So this is not a valid accusation. How is the ICNIRP Commission? First, we can see, I mean, the article ends with the names of these persons who stand behind this false or faked documentation. One would also say that the referee or review process has not been adequate in health physics. I will also say that of these persons, there is only one medical doctor. There is a lack of medical doctors that are involved in these situations. That goes also to different country bodies that have to evaluate the situation. Maria Feisting, vice chair from Sweden, she is by training, she has trained in sociology, so she has no natural sciences since before. And she was the one who downplayed the cephalo findings. We heard Michael Kundi report the increased brain tumor risk in children, which appeared after 2.8 years. The press release from Maria Feisting and Karolinska Institute was that a new study on brain cancer among children does not show an increased risk for brain cancer, which was a lie. And also the Journal for the Swedish Research Fund for Pediatric Tumors in their newsletter reported that there is no cancer risk for use of mobile phones among children. And this is, of course, was not the truth and is not according to the precautionary principle. I would also say that if you have an ICNIRP commission that presents those data, which are so easy to rebut, then you must be very cautious about other publications of these persons. So how can you rely on what they are doing? I will just show a few things. There have come out a number of publications recently where people from ICNIRP are involved. In this article, there were two persons, Karipidis and Croft, because there are other sections in ICNIRP which are also with also scientists. They looked into brain tumor incidence in, I think this was in Australia, and they found that there is no increasing incidence. But the problem was that they stopped at the age of 59, and this represents only 39% of the population. And furthermore, we know that the increase in especially glioblastoma comes after the age of 60. This was, by the way, one of the problems in the Interphone study because they stopped recruiting cases after the age of 60. This is a study from Sweden where they claim that there is no increased incidence of brain tumors. This ended 2012, which is didn't include the most recent data. Two of the authors are employed by the Swedish Radiation Protection Agency, and SSM relies completely on ICNIRP in Sweden in their evaluation of the scientific evidence. And all agencies, they rely on Swedish protection agencies. So people in Sweden who claim that there is a problem, they get automatically the answer that this is within the guideline of exposure, within the limits. So in this study, they showed that low-grade glioma is actually, the slope is going down. But what they didn't show was that for the high-grade glioma, those that are most malignant, the slope is reversed. As you can see here, up to the right, there's a rather steep increase in the raise per 100,000 and the incidence trend, which is going up. And by the way, they stopped here at 2012. So they didn't really tell the truth about the findings in the Swedish Cancer Registry. And more problematic is that the authors have not replied to letters that they have got several letters asking why are the high-grade glioma, why didn't you present them? And they never answered to that. We can actually in Sweden see that for glioma, the incidence is going up, especially here after 2012, but there is an increase from beginning of 2000, and this is seen in the age group of 60 plus especially. And as you remember, the Australian study, they cut off those who were 60 years or older, and so they represented this under 60 years of old. So one must say that statistics show really that there is an increasing incidence of brain tumors. This has been often said that there's no increase in the incidence, so you don't believe in the findings of epidemiology. If you looked into the outpatient register in Sweden and look into brain cancer, the most recent data up to 2018, you can see that there is an increasing number of these, and This outpatient registry started in 2001, so you must be a bit cautious about these first years because there was a lag time to get them reported. But definitely these data show an increasing number over the years, as well as for brain tumors that are not specified. To get into the Swedish cancer registry, you need to have a histopathology. That means that you must have a biopsy of the brain tumor. And we have shown that actually in a paper that we have the MRIs and CT scans now, so they can rather well establish type of brain tumor without taking a biopsy. And for different reasons, some are not operated, being old or having a very aggressive tumor. But we can see also that these not defined brain tumors are increasing in Sweden. This last dip here might be artificial, so that not all from 2018 had been reported at that time. So really there's a steep increase over time. We have published these data also. In Denmark, there is an increase of glioblastoma malignant, the most malignant aggressive type of brain tumor. And this is the percent increase relative to 1995. So relative to this, you have an increase which goes steeply up. And the numbers here, the red ones are the young ones, age under 30 years, which they are, and you can see that they represent rather low numbers. They came some years ago already increasing incidence in Denmark, so I wrote actually to the person who was in charge, but he never answered and gave any more data on that. This is the well-known study by Alistair Phillips in UK, where he can show that we have all primary malignant tumors somewhat increased over time from 2003 to 2013. If you look into those glioblastomas that are located in the frontal or temporal area of the brain, that's the most exposed areas, you have a clear incidence increase over the years, whereas you don't see the same pattern in other parts of the brain. This shows also that when you discuss incidence data, you shouldn't lump everything together. You need to have data on specific size of the brain where there is the highest exposure. You need to have data on types of tumors also. So there are many pitfalls if you discuss this. I will just mention this Cosmos study. You may have heard about that, which is running now. It's paid by the mobile industry, and the lead authors of this paper, which came out recently, are two ICNIP persons. Headache, tinnitus, and hearing loss in the Cosmos study in Sweden and Finland. First, you can see that the response rate is quite low, 20% in Sweden and 7% in Finland participated. What they did was that they sent out questionnaires to people and asked them to answer different questions and also about their mobile phone use. What is very remarkable is that they excluded persons with headache, tinnitus, and hearing loss at the baseline. So those who reported that they already had these symptoms, they throw them out of the study. And if you talk about these as kind of radiosensitivity, of electrohypersensitivity, especially headache, then this will be kind of a healthy worker effect in the study. It means that you have a cohort of persons who are healthier than the whole population. I mean, that's done in some occupational studies, that those who get a disease, they have left the work, and only those who are healthy are still there, and you don't find the real risk. They found actually statistically significant 20% increased risk, but what they then did it was that they adjusted for lots of variables, including painkillers, which I think is extremely questionable, because say that you are investigating infectious disease and you adjust for use of antibiotics. I mean, that's quite obvious that you, in this case, in this situation, adjust for painkillers, which is extremely often used by those with headache. So this is kind of over-adjustment that should not be done. So one can wonder about the medical competence in this group, really, and why they do such. What about 5G? 5G is now, as you may know, at least in Sweden, it's allowed in 700 megahertz, 3.2 to 3.6 gigahertz, and then these higher millimeter waves are to come, but nothing is decided on the installation of those frequencies. Here is a very short summary of the mobile phone evaluation. First, we had the first generation with the extendable antennas, and we get the GSM phones and the smartphones, and now 5G. And 5G, as you know, will have another type of base stations. Here they have kind of a grid with 8x8 antennas. These are all antennas, and this means that there will be lots of antennas in these base stations. And also the technology is quite different. As you can see here, if you have the lower frequency, the violet color here, it covers a larger area. Then you go up into frequency 3.4, 3.6 gigahertz is smaller area, and finally the millimeter waves, which will be very localized in their exposure. And as far as I know, we have an expert here, but as far as I know, there is no regulation still over the 5G technique, how it will work, but probably it will start with, in combination with 3G and 4G, and it seems to be a falsification that these systems will be closed down and it will be lower radiation. But this is something that should be investigated. How does this really work in the real world? Anyhow, I was at a meeting at the Tallinn administration, and it seemed that those who are to decide, they don't understand the technique, that is quite different. It's not the same, just that we add some frequencies, because these beamformed radiation, they are moving around, and we can have a principal mast, and then we need to have secondary base stations to transmit it further in other areas. And they may indeed need indoor antennas, which is in the wrong direction of exposure. This is interesting analysis which was made within EU and presented in April this year. And as far as I know, it has got very little attention. They say that this system will be 3 times more expensive. The whole idea of 5G is driven by telecom, and they convince governments that 5G is needed, and then government convinces the population that 5G is needed, and industry influence on governments that 5G is needed. And of course, one can think of different industrial settings where 5G is of yeah, it comes. Yeah, well, there's no way to measure 5G, and I have talked with our people who do the measurements, and they say the same. There is no way how this can be measured. Well, race to 5G, we'll read about that in newspapers. And in this, now I'm citing this report. The notion of a race is part of the campaign, but it's clear that the technology will take much longer time. And in China, they say that this is a 10-year program. And in fact, the licenses are sold out, and the technology is not known in detail, especially the population does not know much about that. The technique is complex. It gives an unpredictable propagation pattern, and this can give unacceptable levels of human exposure to radiation. This is one of the problems, that these signals can cross each other, as I understand, and may give hotspots if you are unlucky persons, especially if you go to the football stadium where there are lots of persons, maybe 50,000 persons using the mobile phone when it comes with this technique. So, as I showed previously, we have the old technique, which is spreading over a segment of radiation. This is an active antenna technique, which is transmitting to the receiver and from the receiver back. So it goes in both directions all the time. Pulsed radiation, which is more dangerous than the average exposure, which the guidelines are based on. So this is what they call multiple input, multiple output technique between the base station and the receiver. That can be a mobile phone or something else. The range will be very problematic because with increasing frequency, the range goes down. And if you go up to 26 gigahertz, somewhere here, the range is very short. And that's probably one reason also that they start with the lower frequencies, because the range will not be that problematic when they have 700 megahertz, for example. Problems, rain, snow, fog, trees, vegetations, all these will stop the millimeter waves if you discuss them by now, and that's one of the problems. Typical range of millimeter waves, 20 to 150 meters, and lots of base stations are needed. One thing that has not been discussed, and I think I discussed a little bit with Deborah about that, is that all the base stations need a battery backup. So every base station must have a battery, and this is because if the electricity is shut down, then it will work for some time. I don't know how long time the battery will work, but it's the same as for elevators. All elevators have a battery backup, so if the electricity is shut down, it will go to some kind that you can get out. So this is a big problem because huge amounts of batteries are needed, huge amount of replacements over time are needed. And what shall we do with these batteries that are replaced? We have heard that there will be lower exposure, but in fact there will be increased exposure from higher frequencies, but also aggregation of different signals. And the problem is, as I said, the complex beamform transmission in both directions, and this is unpredictable. This has yet to be mapped reliable for real situations outside the laboratory, and it's not done as yet. In this article, they suggest a free installation from next year of 5G, and it's to me unknown if this free installation also means that you have to install them in buildings or not, because that will be necessary, especially with the new buildings which are built with concrete that doesn't permit so high transmission, and also windows nowadays have some kind of film for energy preservation, and they will not easily transmit the radio frequency or high frequency. So if you live in a rental house, will you be forced to put in secondary base stations for 5G? I don't know. We made, actually, Rainer Nyberg took the initiative to the 5G appeal. He's sitting there. And we sent it to EU in September 2017 and asked for a moratorium on the installation because this has not been investigated. And EU responded that that's not their business, really nothing they want to consider, and we have written replies 2 or 3 times, and the last one came 2 or 3 months ago, and we asked for the documents, because legally you can have access to EU documents where they base their decision, and they just responded that we rely on Skinner, and Skinner was organization that made an evaluation at EU some 4 or 5 years ago, or 3, 4, and it's completely biased actually. So, do we need more data, more devices, and instant response? What do you know? I will not go into this in detail, but we have already heard about. I will just say about permanent tissue damage, which is shown by a study by Kuster, usually working for industry. They showed that this technique can damage the tissue even after short exposure. Nobody cares of this study. It came 1 year ago, and it's very important regarding skin diseases. The eye is a sensitive organ, and this is problematic if you have these beams which are active and they cross each other in the eye. What will happen to that? If you have a child on the street and you have multiple devices using 5G and you have these beams sweeping all over, can there be a hotspot, for example, in the eye? I don't know, but that's one risk that would be needed to be analyzed. I will just mention this, as you know, that some countries have lower exposure guidelines compared to ICNIRP, which is the one up here, and you know it's based on only heating for 6 minutes and averaged. No pulses are considered. Well, this is from Ericsson company in Sweden. They made estimates about exclusion zone of 5G with lower guidelines. If the guideline is 0.1 watt per square meter, the exclusion zone will be 150 meters. Here is the ICNIRP guideline, and the exclusion zone is much lower. And here is the guideline of 0.1, as I said. And the conclusion is that 5G network cannot be rolled out. It will be possible. So ICNIRP is making a new evaluation of the situation and maybe going to relax this 10 watts in certain areas to high. I know Finland has already discussed 200 watt within a square centimeter area, because if you average over 1 square meter, it will be much less. And of course, if you average the burning sun in one hotspot over 1 square kilometer, it will be much less. Effects on bees, birds, and plants are of course not discussed. I will just skip this. It shows the cartel, the same persons sitting in different organizations. WHO made in 212 a risk assessment initiative, which is still not published, and you can see the cross-feeding between WHO and ICNIRP and some other organizations. And also, as we learned at the WHO meeting, that they said that ICNIRP is their house organ when it deals with radio frequency radiation. And Mike Ripacoli comes from WHO to ICNIRP. So this is not good for human health or the environment. This is a little the situation just now. What can we do? Well, one thing is that we need to act as scientists. We have measured actually exposure in different areas and published both indoor and outdoor exposures, and just show this from Stockholm, Järntorget. Here is the base station, and this is a popular area in the old town to sit out and take a coffee break or so. And here we can actually see that the top level is 11 volts per meter. And as you may remember, this is actually in the zone where, the lowest exposure was 5 volts per meter in the Ramazzini Institute. So I would say that the exposure here is in the zone where you can have an increased cancer risk. What can we do? Well, IARC is expected within the next 2, 3, or 4 years make a new evaluation. It's extremely important that all persons have a check on those persons who will be nominating as experts. So it will not be a biased group. It cannot be influenced by industry, by ICNIRP. As I said, we have written to EU, it's negative, no report, no positive answer. Nordic countries, the prime ministers, we got only a reply from Sweden. They rely on the Swedish Radiation Protection Agency, that is ICNIRP. Ethical permission, there are two buildings, rental buildings in Sweden where they are going to test 5G because, as you know, 5G is not tested in real world, so they have test situations. So those who are living there, they got a paper saying that don't be afraid, there will be a number of persons running around in the corridors and in the staircases, but we are not just going to test 5G, no problem. So I wrote actually to the ethical committee in Sweden and asked, don't they need to have written information about this and about potential health risk? Don't they need to have a written informed consent from every person living in these buildings? They responded, there is no research program, that's not our business. But they said on the other side that I can appeal to the next level, which I have done. Scientific misconduct, as I showed, is one problem here. This not tested, legal aspects. Can these people go have a legal trial, like persons in ICNIRP and SCENIR for misrepresenting science and not using the precautionary principle? Nuremberg Code was mentioned by somehow, could also be some idea. International Telecom Tribunal in The Hague. It has been done, for example, for Roundup, glyphosate, with some success. Litigations are ongoing in USA and Italy. It's extremely difficult with litigations. If you lose, you have to pay for the defendants, and the telecom has very much money, as you know. The problem is also that those who make the decisions, they rely on ICNIRP. So as far as those guidelines are there, it's very difficult. An alternative to ICNIRP with the scientists that make new guidelines, one thing, public must be informed. In Sweden, it's very difficult because these are not discussed in media, nor TV, radio, or newspapers. And one reason is, of course, the ads. They earn quite a lot of money on those. WHO and EU commissions must be clean from industry control. And also one idea could be have an international database on negative effects, especially when 5G is reported. Okay, thank you.